I guess what I want to emphasize is that what I'm going to talk about, it's interesting, as some people said, that they didn't really know what intersectionality was. Most people said they wanted to learn what intersectionality was, which was a frightening thought, because I don't think I'm going to be able to do that. And that's why I've called what I'm doing the challenges and the potential of using an intersectional analysis. Because I'm going to talk about the way in which I've been working on HIV for the last 8 to 10 years, one way or another. And I think, like some other people said, as I started to read about intersectionality, I thought, oh, but I've always been doing that, but I haven't called it intersectionality, and I haven't formalized it. And I want to emphasize the fact that a lot of the stuff that's been written not only has a very American focus, but I think is highly theoreticized, and I think it makes people scared of thinking in an intersectional way, because they think that somehow they've got to, sound like Patricia Hill Collins or any of the other, Kimberly Crenshaw, or any of these other startlingly bright women, and they happen to be women, maybe they happen to be women, who have written material talking about intersectionality in what is effectively a pretty abstract and politicized way, that they're coming at it from a particular political place. And I think we have to sort of stand back from some of that. And certainly the seminar that you had last time, and then the readings that you were sent out, were, state-of-the-art vanguard writing on intersectionality, but most of them were not about people trying to do research using an intersectional perspective. And I think you mustn't think that you can't do it unless you can do it like that, because I don't think that's what it's all about. And that's why I'm trying not to use the term intersectionality, but rather to say that what's really important is that we take an intersectional perspective on everything that we're doing. And that some of the concepts, when you read them, and try to imagine yourself going into the field wherever it is, and trying to work out, how somebody's identity was formed and shaped in a particular way by this, that, and the other, with very theoretical concepts in your head, then you're always going to feel like you're failing, and you probably won't even start, because if you try to develop a methodology that's going to be acceptable to some of the writers that you read about intersectionality, then I think we're going to get into trouble. And so I very much want to emphasize that I think it can look really scary. The word intersectionality is a bit scary as well. So I think it's very important just to think about what is it that you have to have in your mind when you're starting to do some research which you believe should have an intersectional perspective. And by the way, certainly I think my belief would be that in many areas of health, a research paradigm or a piece of research which doesn't have somewhere an intersectional perspective is probably not going to be good science, but will come up because it isn't reflecting the real world. And so we'll come on to that in a minute. I don't really need to say the basic elements because we've already had it once or twice. That the subject, in fact, I don't think I'll do any of that at all because I think it's all been, well, worth repeating. Okay, so the subjects of research can't be reduced to a single category, i.e. women. Nor will an additive approach be sufficient. So it's not just saying, black and woman. That very, very importantly, personal identities, material lives, and health are shaped by a whole range of variables that are all in constant interaction. And of course, the simplest way of thinking about that is that it happens over time and over space. So the things that are influencing people are influencing them over their life cycle. So it's not a one moment thing. And it's also doing it over space in terms of, where they live, where they move to, and so forth. So we have these categories that are ever changing over time and space. Importantly too, the interactions that shape people's health, daily lives, take place at different levels, as we've also seen. That it's at global, national, regional, local, family, household, incredibly importantly, because a lot of the intersectional stuff that's really important is taking place within the household, which is particularly difficult to explore because of the difficulty of actually getting inside the household to know what's actually going on, if you like. And I've put not just household but intimate relationships, because I think one of the most basic kind of intersectional places that we need to be looking at is the relationships between women and men, and how those are shaped by the circumstances of the women and the men involved. And very often, and certainly in HIV, it's utterly crucial, but very often in research, households become the kind of repository of intimate relationships, but the intimate relationships kind of disappear into the morass of the household, when in fact, there's something actually very different. Well, not different, but they have to be pulled out and explored properly. So the location of individuals at the intersections of these different structures then will play a large part in shaping their health and their well-being. And I've made the point, which has also just been made, that it's very important when we talk about, we say, oh, well, we're working in relation to oppression and vulnerable people and so on, as though we could only use an intersectional approach to talk about oppression, when of course it's also important to take an intersectional approach to understand privilege, and which is the opposite side of the equation. And so we need also, I think, when we're talking about research, to be actually modelling some of the issues relating to how an intersectional approach to privilege, how do people in different positions in society gain privilege, and who do they gain privilege over, and what are the implications of that? And obviously we can go back to the notion of intimate relationships to say that. We might be talking about very poor men, but if we look at the kind of the way in which their society is constructed, then of course they'll be highly privileged in relation to women. So we can't really see the issues about oppression and privilege as being separate. I put that up as just the simplest diagram, and I like it, of intersectionality, so that how people usually work is, as we've just heard, with what's called the Holy Trinity, which is class, race, and gender. And then a person, any individual, will be located in between those things. Sometimes it's easier to think about them visually than it is to think about them, I think, in words. And so that one just kind of says, okay, the simplest way we can think about intersectionality is that an individual that we're going to be discussing or trying to make sense of, their position is going to be where that, right there, where those arrows cross over. But one of the challenges that face people trying to do intersectional research, and that's what I'm really going to focus on, it's not an easy task. In one sense, it's not an easy task, and in another sense, maybe it is very easy, but let's explore that a bit more. It's already been referred to that you can think of it as a conceptual framework. You can think of it as a methodology, or you can think of it as a theory, or you can think of it as a paradigm. There are a whole number of ways of thinking about what it is that we're talking about. I absolutely would want to exclude the methodology model to say there is an intersectional methodology. And it worries me a bit because a lot of people said, oh, I've come today to learn how to do intersectionality and what is the methodology. And I think it doesn't help us to think in that way, because what we have to think about is basically that it's we're talking about a conceptual framework, I would say, or a paradigm. And then when you have identified your problem, what you do is you say, well, I want to think about this problem in an intersectional way. And then once you've thought of it in an intersectional way, then you move on to think, well, okay, what kind of methods would I need to employ in order to get an intersectional perspective on this problem that is the one that I'm basically concerned with. So I think it's better if we don't try to talk about intersectional methodology, because I think we'll get ourselves messed up, and I don't think there is one. So it's an intersectional perspective, really, approach, paradigm, whatever you want. We've already also mentioned the issue of how do you relate the categories to each other, that you can't assume that any one category is more important than any other, except in particular contexts. Now, in particular contexts, some things like gender or like race or both will be the most important categories that you need to analyse to understand the patterns of oppression and privilege and how they're constructed. But you can't assume that a priori. And that gets us back to the whole question about it being a framework, that what you have to be, before you do anything, you have to be actually thinking about, well, what's the situation that I'm looking at? What's the context? Just from the most immediate observation, what are those the categories going to be that are going to be the ones that in this setting or this society are the ones that exert most pressure, if you like, on individuals or groups. So there won't be we can't prioritise any one in principle, but in practice and in a particular context, you may very well, and almost certainly will, be able to prioritise particular categories to understand the patterns of oppression and privilege. So, as I said, no specific methodology is prescribed. You have to work out what you're going to do. And of course, if you have no specific methodology, then there's no specific mode of analysis either. You don't have to do it, in a particular way depends at the very least on whether your study is qualitative or quantitative and so on. So there is no intersectional methodology, analysis rather. The analysis is obviously determined by your framework and what questions you're asking, but there's no particular technical mode of analysis that you need to be thinking that you have to use in order to be doing intersectionality. I think it's good if we think about ourselves as being intersectional and not of ourselves as doing intersectionality, because they're not the same thing, and so it's about a framework. I don't know whether that's come up very clearly, but the other point which I want to emphasise, and which certainly was very important in all the work I've done around HIV, is that there's a big problem of defining basic categories. And again, that has come up in our work in the previous 2 days, because it's a feature of biomedical research, because of the methodologies being used, that you have to take a category like class, or like gender or age or whatever, and say this is a category which I can clearly define and operationalise and use. But of course, in reality, as we've already heard, something like gender or something like class, the nature of what that means in a particular society and in a particular group is not always going to be the same. So you've got to be looking very carefully at what is meant, what's the significance, as was pointed out, of a term like gender in the particular setting in which you're researching. So in a sense, you're going a step further back from a lot of biomedical research where you're actually beginning to deconstruct, you must deconstruct some of the categories that are actually being used through thinking, well, what does that in practice actually mean in this context, in this setting, and how am I going to get at what that means? The special relevance of all this to HIV, I think it's interesting because yesterday, again, when we had the systematic review, or the reviews of research on what were called vulnerable people, it was interesting. I still think that HIV came out as the one where there was more qualitative research, in fact, more studies altogether, of a different, looking very different from those looking at other so-called vulnerable groups. The reason I think why HIV has generated a huge amount of literature that actually is developing new kinds of methods. The reasons people have developed that is, first of all, because of the complexity of the global pandemic. The pandemic is immensely complex, particularly in the sense that there are such great big differences between different epidemics that constitute the pandemic. So if you look geographically at the differences between the US, Africa, and Eastern Europe, then you would find, that the people who were affected, that the demographic pattern of those places would be very different, and related, of course, to the modes of transmission of the disease. But that means that, for example, in Eastern Europe, the biggest problem is among injecting drug users, and injecting drug users are predominantly male, and so therefore you have a situation where that differs a lot from Africa, or the African region, where the majority of transmission is heterosexual, and women are the majority of people who are actually affected. Whereas in the US, it's men who have sex with men who are the major group who are affected. And that means that if you really want to make sense of a disease like HIV and the global pandemic, then you have to understand, you have to be able to make sense of those differences and what the social and economic and cultural and political differences are if a particular disease like HIV is being carried by, is the burden of these very different groups of people. So that makes it, if you take a particular disease, then you can see why, in the case of HIV, intersectionality would be something that would be really important in understanding it. And related to that is that in different societies, evidently, there's a whole range of economic and social and cultural inequalities that shape people's likelihood of exposure to HIV, and also will shape the prognosis that they face when if they actually are infected. So one of the things that you're going to do in your in the group work afterwards is, for example, to say, okay, well, so what if we compare a gay man in Manhattan who's HIV positive with a miner in South Africa in the Eastern Cape, or a woman in Thailand who's working in an electronics factory. They've all got HIV, but what on earth does it mean, to kind of only stress their commonality? They're hugely differentiated, and we need to be able to understand why. And the HIV pandemic shows that more clearly than anything else, I think. Social science actually has become increasingly complementary to biomedical science in making sense of these relationships for the reasons that I've said. And in many ways, probably, again referring back to some of our previous debates, social scientists have probably been able to work more closely, or alongside perhaps, let's say, in complementary ways to biomedical scientists in the HIV pandemic than they have if we took almost any other disease. And the reasons for that lie in that complexity and diversity of the pandemic itself. And obviously, the fact that social science, I mean, those of us who are social scientists and lots of other people would think that was an advantage. And I think it is to have social science added in. But I think you've got extra added value if you're using that social science in an intersectional way. Because obviously some social scientists have come along and worked on HIV, but not in an intersectional way, in a relatively narrow, focused way, very much the sort of handmaiden of the doctor's model. Well, let's find out why people don't adhere to their drugs or whatever it is. But others have taken that much broader intersectional model, which I think has been, a lot of that has been the most significant in relation to contributing to understanding the pandemic, but very importantly to understanding the very varied experiences of people who are HIV positive, but also understanding much better both how to prevent, although I think that's extremely problematic, but more importantly to care for, to appreciate those people who are already infected. I'm going to illustrate that with two examples of my own work. One was 3 very early studies, some of the earliest studies that were done of African migrants in London, looking at how we went about doing that, and then looking later at the book I wrote, which was taking a global perspective on HIV. So I'm going to look at those 2 different areas. So this was just, for those of you who this is just a contextual thing to tell you about HIV in the UK, because this study was on HIV positive migrants, black African migrants in the UK. So in a sense, it was a very interactive, intersectional study to begin with. And you can see that in the UK, men who have sex with men are the largest group, so the blue group. And then we've got African heterosexual women and African heterosexual men. So the purple one is the African heterosexual women, and then we've got the African heterosexual men. Now, this is a very interesting thing, not just for the information that it gives, but the fact that in the UK, all policies basically are designed to either deal with Africans or men who have sex with men. Now, if you're an African man who has sex with men, you're in trouble because you don't know which of those categories you belong to, and you fall between all the different stools of policy in terms of the initiatives, because we have initiatives for Africans and we have initiatives for men who have sex with men. But there's a glaring lack of recognition that quite a lot of those men, the African men who have sex with men, that they exist, and they're quite a large group. And so that's just a very simple example, partly to just show you what the epidemic looks like in the UK compared with other countries, but also to say, well, if we're not being intersectional in our thinking, what happens to these African men who have sex with men? You know, what? And that was one of the things that we looked at in our research. What we basically studied, we basically did in this study, the approach to being intersectional was to do 3 groups, to do 3 separate studies. We did one study that all African, remember they're all HIV positive and they all live in London. So we did one study of women, we did one study of heterosexual men, and we did one study of men who have sex with men. And the main methods we used were semi-structured interviews and focus groups. And obviously all of the 3 studies were carried out with relevant advisory and advocacy groups. Now, I think that what we were doing when we did this research was very much moving ourselves forward into thinking intersectionally in the way that some of you have, described your own experiences. Because when we started off doing the study, we did a study of women, and only women. And the reason for that was because at that point in time, which was about 8 years ago, in terms of the thinking about HIV, most of it was concerned with poor women, particularly African women. It was at that point that poor African women, if you like, were being seen as the focus of the pandemic, because it was at that point that it was moving, had moved from gay men in the north to poor women in the south. And so, like everyone else, our main interest was in exploring the lives of these women. And so that's what we did. But as we did it, and I'll tell you what, basically what we found in a minute. But as we did it, we were thinking, oh, wait a minute, though, what about the men, or what about, and indeed, are we thinking, what about heterosexual men, what about gay men, blah, 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 and so although the study of the women was in itself a perfectly adequate study, for us, we felt like, oh no, wait a minute, what are the links between these different groups? How do they differ? And we really need to know more about them. So we carried on and we did the whole 3 studies. Now, you could say a challenge would have been, if you were wanting to make your study have an intersectional approach, the whole thing, then of course if you'd been thinking clearly at the beginning, you might have put everybody in and compared them and done one study. And we didn't do that because we weren't thinking like that. But at the same time, I'm not sure that how helpful that would have actually been, to have actually been trying to do all 3 at the same time. Certainly in terms of how you asked your questions, how you thought through what you were actually doing, might be a lot harder if you took those 3 groups than if you actually took them. And then, so anyway, my contribution at this point to an intersectional approach was to take all 3 studies when we'd finished and then basically analyse them all together, having analysed them separately, and try to do an intersectional analysis of those 3 groups. And that's the study, one of the things that I actually wrote up in the end, what we could say, if you like, intersectionally about these 3 groups of people. And you need to think about, this is a big question, how are you going to do your study in terms of, first of all, which groups, and secondly, are you going to do them all together, separately, blah, 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 blah. The thing about choosing the groups, in a way, because we were in a particular situation at a particular time, and because our interest was in migrants, then in a way our categories were actually chosen more or less for us, because what we wanted to look at people of migrant status, we wanted to look at women and men in the end, and in the end we also, because it was HIV, we had to say, okay, we need to look at, to use the terms loosely, we wanted to look at, we must look at gay men and straight men. So we must look at men who've been affected heterosexually and men who've been affected through sex with other men. Because it was HIV, but obviously those would not be the necessary categories that you would choose if you were doing a different kind of study. So it's that thing about thinking through, what is it that you're actually trying to find out, and what are the key categories going to be for finding it out. I'll make just one extra point there, which is that the incredible difficulty we had of getting appropriate samples for doing this kind of research, because it was easy to get 62 women because we were working anyway through a hospital, and the women were coming in for their antenatal care as well as for treatment, some of them. Heterosexual men were much more difficult to recruit, and it wasn't because they weren't there, it was because they wouldn't come and be interviewed. So, you get that whole thing about your methodology is going to be very much affected by those people that you want to interview and whether you can get a sample of them. And the fact that you can or you can't is an important part of your thinking about what's going on. So in the end, we got 37 heterosexual men in the end who agreed to come and be interviewed. But the men who had sex with men, as you can imagine, getting a sample of there are no studies of African migrants who have sex with men in London. There just aren't any studies. There's nothing, And so we had to do it in very sensitive kind of ways, and we had to snowball really, going from one man to the next. And it took about 9 months to get 8 African MSM who were also HIV positive. It was incredibly challenging. And so one of the challenges of getting an appropriately diverse sample is that your sampling will itself be affected very much by how easy or difficult it is to approach people and to approach them in a useful way. That we used focus groups for those men as well as interviews, and we had one focus group of 8 African MSM, and it was one of the best focus groups I've ever been in, because they'd never met each other, and they all came from different parts of Africa. And they were all so excited to be there, and we were so excited to be there. Then they organised a barbecue at the end for us all to go to, and it was so interesting, because there was no work done. It was just really, really fascinating, and they were all so different. And one of the things that also to pull out from this is that these men, by and large, would not define themselves as gay. And in fact, when we used the word gay, they'd all burst out laughing, and they go, gay, what are you talking about? Because, of course, in the north and in some parts of the south, obviously, the term gay has come to be used in relation to men who have sex with men. But it does represent a particular type of man who has sex with men. It's a type of man who is out and tends to use gay clubs or whatever. And some of those did, but most of them didn't. And so even when you're taking whatever category you take, you've got to really say, what does this category mean? And what does it mean in this context? And what are the implications of it for what it is that I want to find out? Because obviously it meant that there were loads of men that we couldn't even access. So, it's all of those things about definitions are really important. So just to be clear, so we had the structure of the sample. So we were looking at migrants in the UK who were HIV positive and who were black Africans. And then in the middle of that, if you like, our sample was heterosexual women, heterosexual men, and gay MSM, whatever. So that was how that kind of worked in relation to being intersectional in the kind of approach that we took. That's the sort of visual representation of it. And then we looked at the links, at the intersections and the similarities. Now, I think what was really difficult was, well, as I said, you can't sample by intersection. This is a really critical thing. You can't sample by intersection. Well, I've just supervised one of my best friends to get a PhD, who did in fact sample by intersection, which in the sense that instead of having X number of women and X number of men and X numbers of social class, she decided on the intersection that she wanted. So black woman, blah blah, and then she had a sort of matrix and sampled by intersection so that she would get people from each intersection. But it was jolly hard work, and you could only do a very small study. And of course, in theory, some ideal of intersectionality would be, methodologically, would be to do it in that kind of way. But it's not. It's something you can do for your PhD, but not anything you'd want to do very often. She has got it, though. She got her PhD last week, so that was good. But the big point really is that to emphasize, the participants in all three studies did have major features in common, clearly, because they were all located at the same intersection, that was the whole point, of HIV, migrant status, and being of African origin, okay? So they had those commonalities. But when you looked at it in more depth, there were all sorts of other differences that appeared, all sorts of differences that appeared when you looked at it intersectionally. And the two things that we really had to look at in more depth to understand these differences, to understand these intersectionalities, it was obvious, was gender and sexual identity, okay? Because those were the two identities, practices, whatever we want to call them. Because those were the two things that affect all of these people were at one intersection, but their location at that intersection was affected by whether they were men or women and whether they were gay or straight, if you like. Yeah? Does that make sense? Because it's a quite important point. So we went on then, and what I want to emphasize here is that the Holy Trinity didn't work. That's the whole point. Because we weren't interested in class or socioeconomic status, because most of them were of the same class or socioeconomic status because of their identity in terms of those other three things. So there were a few differences in socioeconomic status, but not very much. And so it wouldn't have made sense to see that as a key determinant of what was going on in their lives. The two things that were key were gender and sexual identity. Yeah? So that was the thing that was important in this particular study, but it might not have been in other studies. So it's that thing about deciding what are the things that construct the key intersections. So when you looked at what all the participants had in common, so they all were totally shocked by their diagnosis. And remember, this was about 8 years ago, before there were so many drugs available, before it was easy to get drugs. So they all expected to die. They were all expressed the fact that they were highly stigmatized among African communities, both at home, that is in Africa, and also in the UK, which meant that they were all very afraid of disclosure and so on. Migrant status meant that, combined with their illness, meant that all of them had problems about income, usually, and certainly that they had less than people in many other English people, the average anyway. But this was the big sort of contradiction that you also have to think about when you put something like this on a global scale, but they also had access to benefits and to life-saving care that they would not get at home. So in a sense, if you compared them with people, their own families, if you like, in other parts of in other parts of the world, in Africa, they had benefits. So they had drugs available, all of them, that enabled them to survive, but they couldn't return to their families in Africa, because if they did, then they wouldn't get back in. So you could save your life, but only if you lived it in the way that the British government required that you lived it, in the sense that you didn't go and come back. And so for many people, that reality was a very harsh reality, but they all had the same reality. And so that meant that for all of them, there was very high levels of anxiety about their immigration status. Everyone was scared of their immigration status. And so that's why being a migrant was a particularly important part of any analysis of intersection, because migration for many of them was more important than anything else. And that was that was the one that came out as dominant for many. But on the other hand, when you put in the categories of gender and the categories of sexual identity, then changes came up between these people, their intersections looked different, because they had their common intersection, but they also had additional intersections that arose from their gender and their sexual identity. And that's a summary, and then I'll just say a bit more in detail about them. The heterosexual women mainly talked about, expressed, lived their lives in terms of the tensions between HIV and African models of womanhood and motherhood. Because obviously, if you've got HIV, well, there are two key problems. I mean, one is that it's difficult to be a mother and you may die before your children. And that's kind of pretty inconceivable, and you may be too ill to look after them. But also there's a whole issue about if you know you're HIV positive, should you go ahead and have a child or another child or whatever. So whereas in Africa, obviously, as in other parts of the world, motherhood is this kind of essence of being an adult woman. And so to be HIV positive and an African woman was absolutely critical. Not so much for the men, as we'll see. For heterosexual men, the main contradictions that came out for them was between illness and the social construction of masculinity in Africa, but in a very different way. Because to be ill, not to be able to earn your income and so forth, this was something that it was very difficult to reconcile, those two things. And then for the gay, bisexual MSMs, the challenges were the challenge of reconciling their sexuality with being an African man, because obviously it's widely recognized that Africa's the most homophobic, the most homophobic region in the world, with many countries still having death penalties for sex between men and women, but not so importantly. And so they had to cope with the problems, on the one hand, of being of a stigmatized sexuality, but also of being carrying a stigmatized illness. And so the stigma and both the practical problems and the stigma that each individual experienced was affected by these things. So women could be stigmatized because they couldn't look after their kids, heterosexual men because they weren't earning money for their families, and so forth. So you get that common intersections, and then you get these other intersections that are coming in because of the other characteristics of the individuals involved. I will miss the next three out because they're just looking at these same points in detail and then go on to the global bit, I think. This was just, these were actually quotes. I'll give you the quotes from people who spoke about the challenges of combining motherhood and HIV. And one woman said, my heart is loaded. And it was a very powerful way that she talked about it. That they lost their moral identity as mothers. I mean, this was a very critical thing. One of the men said, I want to survive and I want to win. But of course, you can't survive and you can't win. They felt they couldn't survive and they couldn't win in a number of different ways if they were HIV positive. And many of them talked about feeling weak and that this was destroying their identity. One of the interesting things was that because they were ill, if the men were ill and the women were not, then the women had to earn the living in the house, and that was extremely damaging to the men, and a lot of them said that it was also very bad for them to be in England because England gave women equal rights and equal this, that, and the other. There was one guy who was really great. He was talking about how he couldn't have sex the way he wanted it because, she was the one that got the benefits from the Social Security. So he had this great quote about how I go in there with a bottle of wine and I say, can you do this? Can you do that? And she says, no, I've got the benefits. office. So there was this kind of very strong resistance to being in England, where, you know, the status of women was perceived to be really rather unrealistic and not very acceptable. But if you had HIV, you know, it was difficult to do anything else. And then one of the MSMs, the quote from them was, "I count myself as being in a different world." And that was because they, in many ways, being an African gay man coming to London was very liberating, and you could, you know, you could be out as a gay man, and you could, you know, mix with others. But on the other hand, you actually couldn't let the other people that most of your family or other people you knew know that that was what you were doing. So there was this real tension between being an African or being gay, and they often expressed that as, you know, I don't know which way to actually go. And if you weren't being intersectional, you wouldn't get any of that out of it. You know, you wouldn't get any of that differentiation in terms of the commonalities of the disease. So what I did was then went on to think that I wanted to try and test out some of this stuff in a global context. And particularly what I wanted to do was to look at the inequalities and the inequities. The most important thing I wanted to identify was the inequities between people who are HIV positive. Not between people who are HIV positive and people who are not, which is what people usually look at. They say, oh, well, there's these HIV positive people, poor things, stigmatized, blah, blah, and then there's the rest of the world. But I think that was a misconception, and certainly from the point of view of intersectional approach, then what you have to do is look at what are the inequities between those people who are all HIV positive, but in very different circumstances. So it's going back to what I said before about a gay man in Manhattan versus a miner in the Eastern Cape in South Africa. You know, their situations are totally unequal, to the extent that, you know, one will have a normal lifespan and one will probably die very young, either of TB or of HIV, because the epidemic is predominantly a joint one in that part of the world, TB and HIV. But of course, so that's my book. So I wrote a book called Living with HIV and Dying with AIDS, and it's called Diversity, Inequality and Human Rights in the Global Pandemic. So it was basically trying to look at these inequalities between people who are HIV positive. But of course, I was doing it intersectionally, but most of the studies that existed were not intersectional. And so what was necessary to do, and this is what I want to emphasize to all of you, it was necessary for me to take lots of different studies and try to create, you know, an intersectional understanding of what was going on without any kind of very artsy-fartsy categories at the beginning, but actually trying to say, well, how have this, you know, take 10 studies and try to kind of mix them and make a sense of it from an intersectional perspective. And it's only a beginning, but it was very exciting. And the reasons why it's so difficult is if you look at most current studies in the world, and I think this is somehow was coming out as well in the talks we've had already about India, that most current studies focus on only one group of people, and usually they're heterosexual women or gay white men. Very few studies in the HIV literature are not on either poor women or gay white men, and although they're beginning to be more on injecting drug users. But there's a really big bias in, you know, who's been studied and why. Very few studies are combined, have been designed to compare the experiences of these different groups in the same setting, and you need that really to be intersectional. most studies of HIV and AIDS are focused either on the developed world or on developing countries, although that's beginning to change. But we've still got a very American-focused literature. Very, very few take a kind of deliberate intersectional approach. And so the work that I did, I just needed to really build up from this by doing a critical analysis of other studies, of existing studies. And I like this quote from Nancy Krieger, which I put in my book at the beginning for thinking about this, which is the way we develop, grow, age, and die, necessarily reflects a constant interplay within our bodies of our intertwined and inseparable social and biological history. Now, I think that's a very important quote for all sorts of reasons, but one of the most important reasons is because she includes biology in it. And because when we do intersectionality, quite often there's a tendency, or when we're thinking intersectionally, we're thinking we're social scientists, we're intersectional, this, that, and the other. And so we don't tend to put the biology in. But when you look at something like HIV, then it's clearly, or any disease, it's very important that you see where biology does and doesn't fit into your analysis, because it has to fit. I mean, we know it fits from the point of view of reproductive biology because we started there and we're still talking about that. But we haven't done it for lots of other things, and in the case of something like HIV, we really have to do it. So we have to be not only intersectional, but wherever possible interdisciplinary, I think. Sometimes we don't need to be interdisciplinary, it depends on the problem, like everything else. But we mustn't get to the point where we're not interdisciplinary as well as intersectional. Okay, so the way that I shaped the framework for it was to say different epidemics, as we saw, involve different groups of people, and they're shaped by different dynamics. And what we have to do is to explore how the specific but interrelated characteristics and circumstances shape the lives and deaths of individuals. And I only focused on people who are already infected, not the issue of how do you stop people becoming infected. And the reason for that was because at the moment there's a massive focus on prevention, and some people are, at the centre, as it were, are writing things about how, the people who are infected, we can't do much about them, they're already infected. We've just got to do something about stopping other people. And since 34 million people in the world are infected and, having a very hard time, I'm very resistant to that view, and so I wanted to write a book that was actually about the HIV-positive population. So the key characteristics that I was using to shape the intersections were, in fact, in this case, socioeconomic status, because it was global rather than just local, as I'd done before. Sex and gender. And I've put sex and gender deliberately because it includes both the biology of HIV, which is very different for women and men, and very different for gay men and straight men, and also quotes race, stroke ethnicity, the dreaded topic. But in the case of HIV, it was also crucial that I add sexual identities and practices, that had to be in there for obvious reasons, and also injecting drug use. So those came out as the kind of key characteristics and variables that I was actually using to refine, critique, draw in different areas of literature in order to be able to do take an intersectional approach to it. And so what I needed to do, and what I did, was to explore these characteristics, but to explore them in different settings and at different stages of life. What I then did very quickly was to deconstruct the categories themselves, because, if we say, well, socioeconomic status is going to be an important category, what on earth do we mean by socioeconomic status? It's like saying, what do we mean by social class, and what do we mean by those things in different countries? there's no standard measurement of that. So we need to be context specific. Most measurements need to be multidimensional, including income, wealth, education, and so forth. So you have to really think carefully about what's the most appropriate definition for you to be using for socioeconomic status. And the other thing is to be really careful not to assume causality in all of this, that we're looking at the intersections between HIV and socioeconomic status. And in general, we might think, oh, it's very easy because, if you're poor, you're more likely to get HIV. And so it's easy. But actually, it's not true. I mean, in many parts of Africa, rich people are more likely to be HIV positive than poor people. There are a number of theories about why that is, which I won't talk about. But, of course, in general, we've got that picture where if you compare rich countries and poor countries, then the poor countries have higher rates. But the US is very high and also is pretty wealthy. So there was a lot of confusion about the relationship between socioeconomic status and HIV. And of course, also, in many settings, HIV itself reduces your socioeconomic status. So the causality may go a number of different ways. So you have to be thinking really carefully about how you actually use the concept. It's not obvious at all. What is obvious is that the poorer you are, once you've got HIV, the worse off you'll be because you can't deal with it properly. But nevertheless, it's a very complex relationship. If you deconstruct gender, then, as everybody here I'm sure knows, sex and gender are often used interchangeably when they shouldn't be. But in this case, we have to actually do sex/gender because women are biologically more vulnerable than men to infection with HIV during heterosexual encounters. And so what you get is biological vulnerability intersecting with social gender inequalities. So you've got the fixed biological vulnerability and then social gender inequalities. In the sense that, in patriarchal contexts, women have almost no autonomy in relation to their own sexual lives. And so it's very important to have both sex and gender in there, whereas in other settings, the sex might be irrelevant, but in this case, it's not. And of course, it's also important in relation to the fact that being HIV positive has an enormous impact on women's reproductive choices and whether they, as we said before, whether they can have children or not have children or whatever. So both sex and gender have to be there, and we have to be thinking through the implications of those. And then just lastly, of course, and I can't spell it out here, we also have to look at the implications of gender for men and how gender, well, we've already seen how gender challenged many men's sense of masculinity. But it also, of course, is important in terms of looking at the causes of HIV and whether men are living in societies where their masculinity is defined in relation to, how many women they've slept with and so forth. The gender race thing, people, we talked about this the other day, different countries use the concept of race and the concept of ethnicity differently. And they're both incredibly complicated. And using race in a biological sense is clearly not one that we'd want to do. Ethnicity raises all sorts of problems, which again we discussed. I mean, how do you define ethnicity? How do people themselves define it? There's a whole range of problems with ethnicity as a category. But in the UK, we're using ethnicity always, and as I said before, in the US, they're using race. But the preferred alternative, I think, when you're looking at any category related to race or ethnicity, is that what you're referring to is the degree to which people come from a subordinated racialized group. So, and I suppose I just want to I like using this quote, race and ethnicity, from Collins, race and ethnicity are poorly defined terms that serve as flawed surrogates for multiple environmental and genetic factors in disease causation. So whenever we see either of those words, we have to go, whoa, what are we actually talking about here? And particularly, what are we talking about in this context? The last category that we were sort of deconstructing really was about sexuality, which is obviously, again, a really challenging one. We need to look at MSM, again, in a sense biologically, because the particular risks of anal sex are greater than heterosex, apparently, although there's some debate, but also because it's a stigmatized and concealed identity, and as we said before, it's an especially diverse group, that the men may be out or not out or whatever, so it's an extremely diverse group. And so, in fact, one of a recent report by, I can't remember, talked about the invisibilization of African MSM as a major source of risk of HIV and a major reason why the epidemic or the pandemic was spreading in Africa. And that's clearly incredibly important. So when we talk about it being a heterosexual epidemic in Africa, we don't know the degree to which actually it's also an epidemic of men who have sex with men. We actually don't know, because the data is almost non-existent because it's so difficult. I've mentioned here that there's very little written or discussed about lesbian women, because they're obviously less likely than men to acquire infection as a result of same-sex relationships, so they haven't been included. On the other hand, transgender people have particularly high rates of HIV, so you have to be able to kind of frame the diversity of those of that group as well, and in your analysis. Okay, I'm going to go to the end now because I'm going to drive you mad otherwise. And obviously, as we've said, I had to pay attention to IDUs. What I did was to say, in the book, was to say, well, how do we said, okay, so we've got all this, how do we put it together? How do we have a shape for it? Because there was so much stuff pouring out of my room. And so the way the book is structured is through these categories of life, if you like. We say how do the intersections appear in different stages of life and in different aspects of life. So the categories, which basically are chapters, was first of all the way in which people's identities and their own narratives, I mean their identities, let's say their social identities and their own personal narratives of those identities change across the life cycle. And that looked particularly at stigma and discrimination, but it also looked at issues about activism and why some people end up being activists in relation to HIV and other people don't. Then there's a chapter on depending on healthcare for survival, because obviously the thing about HIV is that people are put in a position where unless they have access to drugs, they will relatively quickly get AIDS and die. And so people who live, particularly those who live in very deprived areas, are dependent on the supply of drugs, and there will be many obstacles to the supply of those drugs. And so this question of how you live depending on that, or how you choose not to depend on them, and to say it's not worth it to me, it's not worth it to go on and have all the side effects and not, if you're in a certain context, not be able to drink or smoke, or particularly men said, well, they tell us not to drink or smoke, and I can't do that. Or some very basic things like you're supposed to take your drugs with meals, and of course some people don't have meals, and I had one quote in the book from a woman who went to the doctor and said, I can't take it with meals, so I went out and picked some grass from the field, and do you think a lump of grass counts as a meal? And you're like, yeah. So depending on healthcare for survival was a whole category, what that was all about and how people related to the medical treatment. Then I had a section on changing livelihoods, which was basically about HIV and work, and it explored issues about occupational health, but mostly it was about losing your job or not being able to do domestic work and not being able to do subsistence labour. And so the whole range of labour and livelihood and how that was affected by HIV was another section. Then I looked at the whole issue of sex after diagnosis and how it affected people's sexual lives. And in that case, the really interesting thing, I suppose, was the difference between heterosexual women, heterosexual men, and men who have sex with men, because the experiences that they had were in some ways similar, but in many ways different. And so I tried to put them all together into one chapter, because in general the literature on men who have sex with men, particularly around sex itself, is very separate from any other. So I tried to kind of put all that into one chapter, and it was very difficult. And and then the last chapter was about reshaping reproductive futures. So it was about contraception, abortion, motherhood, all of those things, and how that was affected by HIV. And so the ultimate question really that I'm leaving you with was how to use this intersectional analysis approach to help to achieve an equitable strategy for helping to meet the needs of positive people who are still striving for an improved quality of life and death as well, because obviously a lot of people are dying in hideous circumstances in the poorest countries, not even the poorest countries. And so we have to look at both of those and I think intersectionality helps us with all of that.